So here we're presenting our data of circulating tumor DNA dynamics in patients who have hormone receptor positive, HER2 negative early breast cancer using an ultrasensitive tumor-informed assay. So the purpose of this was to understand and to look at the circulating tumor DNA in patients that have early stage breast cancer, hormone receptor positive, HER2 negative. And this is important because when we talk about ctDNA shedding, we always feel that there's more shedding going on in triple negative breast cancer and HER2 positive. So this is, a first time that we're seeing this, in specifically in this subtype of hormone receptor positive, HER2 negative, because these are considered challenging to track, especially with non-ultrasensitive assays. So for this particular study, we use an ultrasensitive assay, which is the NeXT personnel, that we use to detect MRD or molecular residual disease. And we use this to associate that with recurrence in this particular subtype. So this is a retrospective study. We started collecting data since 2018, all the way up to February of 2025. These were all patients that had stage 2 or 3 hormone receptor positive, HER2 negative. And these are patients that were being followed in clinic during their routine oncological care. So we would enroll these patients and consent them and request them to get blood samples, and we would bank them. So we were banking these samples for many, many years. And then for this particular study, if a patient had provided at least 2 or more samples, and there was enough adequate tumor material to perform the assay, because these are tumor-informed assay, then they would be eligible. We were able to enroll and have 28 patients, but 2 of them, the tumor material was not sufficient. So for this study, we are looking at 26 patients. Now these patients were followed over time to assess for disease recurrence. Because this is a retrospective study, the results were not reported to the patient nor to their clinician. So this is just purely observational. And the NeXT personnel assay, there is already published data on its analytical validity. So this is, if you're interested, there's a paper on this, on the analytical validation of the assay itself. Going to table 1, and it talks about all the 26 patients. Median age around 56, but we did have some young patients all the way up to 71. 48% were stage 2, 52% were stage 3. Median follow-up was about 5 years. We had patients that were followed up to 11 years, in the sense that they've been followed up since surgery. We started collecting data years after surgery, so that's the reason why they came up to 11. Most of these patients, almost all of them, received chemotherapy, and about 70% of them were in the neoadjuvant setting. These are considered high-risk patients. They, of course, all received endocrine therapy, mainly aromatase inhibitors. Some of them received tamoxifen, but then eventually moved on to aromatase inhibitors. 3 of them received abemaciclib, because, of course, at that point in time, this is when abemaciclib was approved, and therefore 3 of them received that. So we got information about that. And about half of them were receiving extended endocrine therapy, which is definition is they were receiving it more than 5 years. Now, the detection, in regards to detection of MRD, these were serial samples. So, of course, the range of the samples per patient, they had to be at least 2, but some of them up to 9. The total number of samples for the whole 26 patient cohort was 118. So these were the number of samples that were analyzed. The median time from breast surgery to the first sample was about 12 months, about a year. As you can see here, there's some patients that first sample was way after surgery. That's the reason why we have a large follow-up time. So these are patients that would have been followed in a surveillance fashion, and we started collecting blood many years after surgery. The median time between samples, because we would get serial samples, was about 7 months. But of course, because patients come to clinic every 6 months, patients come to clinic every year. So whenever they would come to clinic, we would get their sample. The concentration, which is important for an ultrasensitive assay, median was 70. But as you can see here, it goes down up to 14.9. This is the interquartile range. Very important for these ultrasensitive assays is that of the 118 samples that were the ones that were positive, 58% of them that were positive were in what we considered an ultrasensitive range, meaning less than 100 parts per million. That means that if you use other assays that are not very sensitive, these would have been considered a negative, right? So that's important. Here at figure 2, we have 3 panels. So here at panel A is the levels of ctDNA for the ones that were positive, right? And so as you can see here, we run a line on the 100, which is considered, anything below that is considered ultrasensitive. So you can see how the ones that were positive, and then here you can see that 83% of them, the lead time sample. The lead time sample is the sample that was for the first positive post-surgical detection. So the ones that were positive, the ones that were positive, we'll talk about this, because that's what we call the lead time. 83% of them, that first one was below 100. So that's important. Here, we actually look at the lead time. So the lead time, the definition of lead time is the time between the first positive ctDNA and the event, which is the recurrence, right? So we can see the lead times here. As you can see, the lead time in years, and the median lead time was actually 1.5. And then we can see here the Kaplan-Meier curves, and this is for distant recurrence. And as you can see that there's a quite impressive separation of the curves where the patients that were either negative or cleared, and we'll go over that in a second, there was no distant recurrence. But the ones that were positive or became positive, they all recurred. So let's look at the numbers themselves. So when you look at the dynamics, you have literally 4 options. You have patients that were positive all along, like from the first, the subsequent ones. So, patients that have negative all along, so negative, negative, negative. Patients that cleared, meaning that they were positive at the beginning or the first samples, and then they cleared, and of course they cleared with standard oncological therapy, because this is an observation. And then the ones that were negative, but then they became positive. So we can see here that 3 patients were persistently positive all along, and all of them recurred. Patients that were persistently negative, none of them recurred. The ones that were positive at a certain point in time, but then cleared, none of them recurred. And the ones that were negative, but then became positive, all of them recurred. So, and you can see here the distribution of the disease recurrence with the dynamics of that. So figure 1 is the swimmer plot of all 26 patients. And the way it's graphed here is based on their tumor, their staging. And we can also have the clinical stage on each one of them. So like this stage 2. And then if the little circle is blank, that's a negative, right? If they start becoming gray or black, that's a positive. And also the shade of that will give you how positive it was in terms of part per million. So you can see how the dynamics and the follow-up years from surgery. So for example, just this first patient was stage 2, 2 samples, no recurrence here. Let's say this one over here, right? And there's a stage 3A, and all these samples were negative, negative, negative. So, but then for example, this patient, right? This patient is a 3A. There was negative here. This is years from surgery, right? So negative, 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 negative. This one became positive, right? At around, but it was less than 100, which is considered the ultrasensitive. And then the next one was very positive, and then the patient recurred. Clinical recurrence. If we look at one that, for example, this patient 3A, first sample was positive, right? Ultrasensitive, but eventually cleared. Clear, and this patient has not recurred so far. So it just gives you, if you're interested in knowing what happened to each one of these patients. Some of these patients, we were able to get the sample before surgery. Time 0 is surgery. So some of these patients have, and all these patients that had samples before surgery, mainly at diagnosis, they were positive. So like their baseline, which is good, right? You want to have a sensitive assay that at diagnosis it's positive, which is what you expect in some of these patients. So the conclusions of this study is that using an ultrasensitive assay, which is tumor-informed, all these patients are hormone receptor positive, HER2 negative, which again is considered a kind of like a low shedding tumor type compared to triple negative and HER2 positive. All the patients that relapsed or had a distant relapse had MRD prior to their relapse. And this lead time, which is the time between that first sample that's positive and that disease recurrence, is about 1.5 years, which is, it's a lot. That's, it's 18 months, which, the purpose of this is to see if we have a time frame where we can probably intervene, in the sense of changing the outcome of these patients. So this is where the interventional trials come into play. And the assay itself, there's a strong correlation with the dynamics. Again, patients that clear do better, patients that don't clear do worse, and the patients that were negative to positive also do really bad. And the patients that were completely negative all along, they do quite well, which opens up, again, the idea of maybe these patients don't need all the therapies that we give them because they've been negative all along, right? And so there's a strong correlation with the assay and outcomes with 100% sensitivity. And, until this follow-up, of course, you could argue, well, what happened to this patient over here? But until now, it's 100% specificity also.